4 nurses, and 1 pharmacist.
Oh, okay. I thought you said 3 adult nurses and 2 pediatric or something, but no.
No,
So
sorry.
it's
My
split.
mistake.
Okay.
My mistake.
Okay. No, good. Okay.
Yeah. So the total of 8.
Yeah, I've already talked to our pharmacy team. Obviously, Diane is aware of the, on the nursing side is already making some plans.
Cool.
I figured with our pharmacy, we'll have them spend 1 or 2 days on the inpatient, 1 or 2 days on the outpatient, and then,
Wow.
have the chance to think of things and observe things. And
Yeah.
then for the physicians, we will, I think two of them Dr. Nemechek's planning for them to spend at Peds, but also to see our laboratory and see some of what we do with, on the basically sample handling.
Yeah.
And then the adult person we'll do our best to entertain between showing our volumes of inpatient, outpatient, and everything else that comes.
Entertain. I think they will be like shocked with the numbers that you guys are like having.
I think they'll be shocked more in how we're handling them. I mean,
Oh,
right now we're at such capacity. Like I think we just heard there's many patients are just staying. I mean, if they get to the emergency room and someone decides they need an admission, it's often 24 hours in the emergency room before they can actually transfer to get a bed.
wow.
So the emergency room is managing the patients while waiting because there's just no place to put them. We're so packed.
Wow. That's crazy though.
Yeah, it is a little crazy.
Anyway, we are so glad that you enjoyed this trip, and then we hope that we're gonna see you next year with even more excited activities coming.
Yeah, well, I think we have some. There will be more. There's going to be there's other things to work on and continue to build.
Yeah.
Yeah, I
I mean,
definitely am not planning. I mean, as long as you guys find it that I have something to offer you, I'll be glad to commit to the time and coming over and helping out.
we I mean, like myself, I really saw a big difference between the year before and this year. There's a great input of both sides, and then like people are more bonding to each other.
Yep.
And
That's
I mean, like I think we get a better, clear pictures of what others are doing.
and that's the goal. The goal is to break. They say break down silos and prove that it's a community.
Yeah, yeah. And I mean, like we also have a CIBMTR, which is another goal that I think
Yep.
that we will see a big difference a bit later.
Yeah, I've got an update for that too. I spoke to Dr. Shaw 2 weeks ago.
That's wow, looking forward. But
Yep.
even though we don't have that much case, but as you said in the wrap up, we need to be very like precise on like on size that we want to grow, and we need to be clear, otherwise like if we grow up to your level, which is a bit like crazy.
Which is something I have no doubt that you'll be able to do.
Yeah, I think our team able to do. I mean, especially with the pediatric team, they are very, very strong.
Yeah, well, pediatrics, it's strong, but even here, our pediatric team only does about 30 to 40, while we do, close to over, be continuing CAR T, we're doing close to 350 adult procedures.
Oh my god. Okay.
Hi, Prof.
Hi.
Good
Hi,
morning.
everybody.
We have 1 more minute.
Yeah, I'm just boring everybody with telling stories about, what we do for Halloween. It's almost Halloween. You go trick or treating for candy.
How come I don't have it?
I don't know. You got the really good lollipops and big Hershey bars. Justin's just joined. When you go to Justin's house, he gives those $3 candy bars out.
Justin, we need that.
กายอาจารย์สุรพลไม่ได้ลืมใช่ไหม
ไม่ได้ลืมค่ะ
I just called him already ค่ะ
Okay. Prof. Richard, could you please wait 1 more minute for Dr. Surapon?
I'll wait 1 minute. Yeah.
Okay, thank you. So, our team, our 8 people, we have bought a ticket for them, ready for December 4 to 8. The trip to.
Oh yes, now Jenny was just filling me that, you got 8 people coming. We were just saying, Diana is working with the nursing to make a program. Anita Nemechek is working. We'll take care of the 2 pediatric team, and I've already talked to the pharmacy for inpatient, outpatient, who are planning to, show a combination of how we use the electronic record for chemotherapy administration, how show, we have a team of inpatient and probably have how our inpatient pharmacist rounds with the transplant team or the cell therapy team. And so spend a couple days on the inpatient, couple days on the outpatient setting because they do patient counseling. They review all the orders and all the infusion. Our infusion site is like 50 chairs. And so they're pretty busy there too. So it should be a good opportunity to learn something.
Thank you, Prof. Dr. Surapon joined already. อาจารย์สุรพลสวัสดีค่ะ
Say again.
อาจารย์สุรพลคะสวัสดีค่ะ Good morning. You might mute the microphone.
I have a microphone. Does it not? You can't hear me?
We hear you, but I'm just mentioned to Dr. Surapon that his microphone is mute. So.
Oh.
Hello, Richard.
go.
How are you?
I'm good.
Okay.
I'm very good. So I'm looking forward to sharing with you, talking to you. I think we can start chatting a little bit, maybe now.
Yes,
Is that all right?
You can see me?
Say what? I can see you.
Okay.
You look happy.
You too.
So just a brief. I'll save for another time, like a debrief of the last meeting. Of the visit. I'm still thinking about that, and plus I got back and it's been a little hectic. It's been a very busy time the last 4 weeks. This is actually I'm ending up giving 4 lectures this week on all different subjects. Yesterday I gave one to a large company that's interested in cell therapy, what we can do, what our capabilities of how we can run a cell therapy program and what it takes to run a cell therapy program. Just a little while ago, I was talking to, we have our state health system, our government health system, and I'm on an advisory board on drug shortages, and there's some major national cancer drug shortages that's causing impact. And now we're talking here, and I have a presentation, and then on Saturday, I'm giving one on cytokine release syndrome. So it's a busy week besides getting the grant in and going and taking care of a ton of patients. And it's a great time. They say if you're not busy, you're just wasting time. So I'm trying to be, not waste time. So I will share. I did go to Washington D.C. 2 weeks ago for the national transplant meeting that we have. I did talk with Dr. Bronwyn Shaw, and I said, how you guys are preparing. She's very excited, and I told her that, we'll work to make the connection now, and we talked about what we all talked about, and she agrees that at least for the first year, 2 years, just concentrate on the TED forms. They were happy to hear that, you guys are motivated and interested, and hope that whatever you start, that it will continue to grow and involve more and more, and that it will help to create a collaborative venture across all your across all your centers and across all the hematology programs. But you guys will be leading it. So like I said, I have to make that. I will make that follow-up connection. And as I said, I will give a summary. I have a summary of what I've done from observations from last time, and I'll get that together, for you at some point. I look forward to all of your people coming to visit. And then as far as today, I looked back the list of the subjects we talked about in August, or we talked about for this year. And I know that I've given 2 presentations that are disease focused, explaining the role of CAR T in disease. I did CAR T for ALL and CAR T for lymphoma. And although that, yeah, and we will have a whole host of transplant sessions coming, but I thought maybe what was on the list is about just a basic overview of CAR T. And what I decided to do here is just give you, is to give you a talk, but also the slides will give you a complete overview of how we manage CAR T, our CAR T program. So I can go into that, but before I start, are there comments or questions from people? Guess no comments? And
No.
then what I'll do is I'll just start.
Sounds great to me.
All right, what I'll just do is start sharing the presentation. Jenny and I already checked. We think it's working, as opposed to sometimes it doesn't work. Hopefully you all can see that.
Yeah, I
Yes.
can see.
Okay, good. Just checking. So,
Well done.
this is number 18, I think, not 16. That's why I already found a mistake. Anyway, I call this cell therapy is here to stay. And so I may have shown a couple of these slides before, but a lot of it you haven't seen. So, because it's literally the nuts and bolts of the bread and butter of how we do this. So next slide. So I said, first of all, why do we know CAR T is here to stay? In the middle, this is a screen and a screenshot of the 5-year view of cell therapy in the world, where it is in the world of industry. Currently, these are the drugs that have been approved. There's 6 CAR T products that have been approved. There's some drugs that have been filed. There's been filings like where the Iovance is maybe the next one, or Obicell may be one. Lysocell for CLL may come. So there's some short term, but there's some in pivotal trials compared to that's often what it takes to get compared to standard of care. Phase 1 and 2, and then a whole host of potential targets and experiments in the preclinical that may go into either pilot studies or into phase 1. And you can see there's a heck of a lot of different cell types. So, the take-home message isn't that everything here is going to come to fruition, but also the take-home message is some of this is going to come forth. And we are going to have a host of cell therapy drugs in the future. And these are the United States and some countries in Europe. We've talked about the economic barriers, but at least I'm just going to talk about this. And we're not necessarily going to solve the socioeconomic issues right now, but I know you guys are already treating patients with some autologous CARs that are self-generated. That's perfect. But let's just look about CAR therapy. So again, we talk about CAR T cells, but there's a host of immune cell types that can be exploited. There's T cells, there's natural killer cells, dendritic cells, and of course there's lots of antibody variants that are all part of immuno-oncology. And then also the cytokines. We still can treat people with interleukin-2, and that's, if you're going to use tumor infiltrating lymphocytes, interleukin-2 is almost necessary afterward to expand the T cells in vivo. So we have a host of agents that are going to be utilized. I think I have shown this slide before. A lot of people, if you look at this is from Carl June, who just, who's, Carl June at Penn, who helped develop tisagenlecleucel, CTLN19. This is the world of industry, not basic research, but industry, with the first cell therapy approved was Dendreon, the Provenge for a dendritic vaccine for prostate cancer. We then all of a sudden see the next, that was in 2010. Now that's almost off the market now because it's not as effective as other therapies. People aren't using it, but it started the pathway. We have a series of antibody therapies that took over for the next 5 years, and the checkpoint inhibitors, which are all standard of care, and then bispecific antibodies. And then around, actually 2017 is the first official approval of CAR T. And then we have multiple therapies under development. And that's what the blue triangle shows. It starts at a single point, but it is dramatically expanding. So when I look at the history of CAR T, people have actually published this. If you go back, I'll tell you, in the 1980s, I made a lot of intraspecies molecules. Like I did genetic engineering of HLA with mouse H2, and we were dissecting the immune responses and the cross-species interactions and the ability of cells to study adhesion. But right around the 90s, people started to make fusion, like I made fusion HLA molecules. They started making fusion accessory molecules. And a lot of people put that as the start of T-cell engineering. And with 1993 is the first time they actually created a hybrid molecule, expressed it in T cells, and then started to study the biology. We developed co-stimulatory molecules. But even then, you can see now in 2003 is the first experiments where someone's developing T cells that could see CARs. That was the first generation. 2009 is when tisagenlecleucel, or CTL0119, was did their first phase 1 study. And basically, for the next 5 years or so, we were seeing all the clinical trials with tisagenlecleucel, axicell, axicabtagene, and now we start to see the licensing. And in the red are the approvals, the approval dates, and the indications for the agents. And when we look at them, these are the approved CAR T products and their specific indications. So there's 6 products, but like tisagenlecleucel's got 3 indications: pediatric and young adult ALL, third-line adult large cell lymphoma, follicular lymphoma. Look at axicell, it has third line, it has second line, it has follicular lymphoma. It's got three indications. Brextacabtagene has got mantle cell lymphoma and adult ALL. So some of these are not they've been approved for multiple indications. The FDA has made recommended dose schedules for lymphodepleting therapy, and also you can see some of them recommend rigid adherence to a schedule to administer the lymphodepleting therapy. Some also say, you know what, you got flexibility. The key is lymphodepleting chemotherapy makes someone immune suppressed, and you can give the cells within a window. And so there's flexibility. So it depends on which drug of which regimen you use and how it's used. The reality check, which is the real reality check, and I know, what's it, 30, when I was there, it was what, 35 bots to $1. So you have to multiply, I don't know what it is now, I have to go, multiply by 35. WAC means wholesale average cost. So 2 products, the brextacabtagene and the siltacabtagene, which is for myeloma, and this is for adult ALL and mantle cell. That price is fixed right now. It's not changing, but it's basically $480,000 for myeloma for a drug that doesn't cure people, and $424,000 for Tecartus. These were the prices that we paid for Kymriah, for Yescarta, Abecma, and Breyanzi, and you could see in 2003 and now 2024, these prices are going up. So that's what it costs me to care for that's what it costs OHSU to buy the drug from the company, not to mention the care of the patient. And so what we want to do is, if we're going to do this, we want to be specific, pick patients who we think is really going to benefit, and also, as much as possible, be as efficient in the delivery of care as possible so we can maximize the value and justify the expenditure. So what I put together is a series of guidelines, and I will send the slide, as always, I'll send the slide set when I'm completed, but you can see, you can use it, you can adopt them as you wish, you could throw them out and build your own, but this is what we do here. And so first of all, we're going to say, how safe is it for a patient to be treated? So we set up, the first guideline is, okay, we're going to treat a patient. We have, like I said, I have patients who come from 400 miles away. Well, what's the maximum distance that we're going to allow a patient? And this guideline is also shared with transplant. So if we're going to try and do outpatient transplant or outpatient CAR T, we're saying patients basically should be within 30 miles of OHSU. In general, you can get here within 30 minutes, maybe in traffic it'll be 40 minutes, but that's if we're doing outpatient care. And this is prior to the actual infusion. For once we do the transplant and have follow-up care, we want the allogeneic patients to stay within 25 miles, a little closer than 30. So that's a 30-minute drive until day 100. Autologous patients, transplant, and CAR T patients, we recommend staying up to 30 days within 1 hour we have time. If these people, autologous and CAR T, if they get fevers and get sick, they have time to get to the hospital. The allogeneic patients often have the gram-negative sepsis, and we want them much closer for a longer period of time. So we thought that was an important guideline to say, if we're going to treat you, where do you need to live? Now, in Bangkok, you've got a population of 12 million people. 30 minutes or 25 miles maybe take an hour and a half. I've been in that traffic. I now know the traffic. You may choose to pick a much shorter distance because it's all about getting the patient the care they need when they need it. On the next guideline, we want to make sure there's responsibilities in CAR T when it's not like getting cefepime from the pharmacy and giving cefepime, and you don't really have to track the doses. There's a big chain of custody and responsibility that the FDA has placed on treating centers, which is that I have to minister the drug in a safe fashion, but I also have to follow them for those adverse events of special interest, for cytokine release syndrome, for the neurotoxicity, the ICANS, the immune cell associated neurotoxicity syndrome. I have to track the toxicities. I have to grade the toxicities, and I have to report them. By day 28, any of the adverse events has to be reported to the FDA, and we do it by day 42. So we've identified people who are responsible for that task. So if my inpatient doctor is taking care of somebody and they get sick, and it's my patient, as an outpatient doctor, I'm in charge of that FDA report, and we have a program manager working alongside me to assist. That report will include details of the patient, justifying that admit the criteria for administration of a CAR T product, the day that I gave it to them, and the actual clinical course, what happened and what were the adverse events. And we save this all in the electronic record. So we have the entire history of our program stored, for further later research. This applies to all patients receiving CAR T therapy. And the expected outcome, if we do something, we have to have a reason why we're doing it. Basically, we know that this is the requirement of the FDA and we have to meet that requirement. And so that's what we're trying to do. And as far as, okay, so now I'm saying I'm taking responsibility of reporting and following all the regulatory aspects. Well, how am I managing that patient? Well, currently what we've said is for all patients receiving immune effector cell therapy, we have a plan. This is the adult schedule. This is our schedule. Following the infusion, the patient will be seen daily for 7 straight days. Some of these patients could be really local, or we could do it as an outpatient. Going to see them for 7 straight days. If they're inpatient, we're going to see them. In week 2, we go to every other day visits, and for the weeks 3 and 4, we basically go to twice a week, and we're monitoring for symptoms of cytokine release syndrome or the neurotoxicity. But it's really critical. We know that, and a lot of this is based on the biology. We know when the CRS is going to appear. We know when the ICANS is going to appear. And by this close surveillance, we're going to make sure we don't miss seeing it and intervening appropriately. So the next set of slides is how do we manage cytokine release syndrome? So what is cytokine release syndrome? I know some of you know, but maybe not all of you know. It is a supraphysiologic response after any immune therapy. It isn't just CAR T therapy. So I say, if you use interleukin-2 for treatment of renal cell carcinoma or melanoma, you can actually induce cytokine release syndrome. When you use haploidentical stem cell transplant, when you do haploidentical stem cell transplant and don't give post-transplant science until day 3 or 4, you'll start to see some patients, based on the T cell dose they get fevers or tachycardia. That's cytokine release syndrome. Some people will get hypoxia. So it's a supraphysiologic response after any immune therapy that results in the activation of endogenous or infused T cells or other cells, the macrophage in the background. They can be progressive. However, it must include fever at the onset. By definition now, if you don't have fever, you don't have CRS. That's the official definition of by ASTCD guidelines. You can have hypotension, capillary leak with hypoxia, and end organ dysfunction. You can have, what do we expect to see? On an individual organ system, we may see symptoms. Where certainly systemic fever is common. Cardiovascular, we're always watching for hypotension, but we can see tachycardia. I had a patient who was able to maintain her blood pressure satisfactory, but she was running sinus tachycardia at 150 to 160 and was able to keep it up with that. That was actually in a post-transplant cytoxin patient, but that was CRS. And hypoxia is tachypnea. And it's always important when you have fever, though, you can't assume it's CRS. It's always a diagnosis of exclusion. You got to look for a source of sepsis. This is the grading system, and I think you all are aware of the grading system. This was between 2012 and 2018. There were multiple grading systems. Sloan Kettering developed one, NCI developed one, University of Pennsylvania developed one, City of Hope had one, and everyone was publishing their data with a little bit of variations in the theme. But basically, in 2018, there was an invitation of 50 people. I was one of those 50 to go to Washington to come up with a consensus grading of CRS and ICANS. And this is what it came up to. And you can see fever is mandatory to get a grade. Also, there's the low blood pressure. If you have hypotension, you immediately become grade 2. If you have hypoxia, it can be grade 2 or 3. What they put, they're very aware that when someone gets in the hospital, someone may put nasal prong oxygen on them. Well, that isn't enough to declare that they have a CRS grade hypoxia. It's all based on whether the oxygen is delivered at a high flow. 2 liters of a nasal oxygen does not give you a CRS grading. It has to be greater than 6 liters a minute to qualify. So what do we know are factors that predict for CRS? ALL is more likely linked than lymphoma. If you wait and don't use, now we know if you don't use TOSI early, I mean, and you postpone its application to 72, 96 hours, you're more likely to have severe CRS. The low transduction frequency, maybe that seems to be linked. And then we have severe neurotoxicity. It's definitely seen more with we'll talk about that in a minute, the CD28 sequences instead of 41BB and in the elderly. And actually, age over 21 was more likely than under 20. We now know that age over 65 is more likely than the under 65. And on multivariate prediction, we have these other findings that are very predictive of severe CRS. We want to avoid severe CRS. And this is a little bit of a view showing you this from, so what happened, this is from the FDA. Actually, this is based on all the MedWatch reports. The FDA collects the data, and they actually presented to the ASTCT at a meeting on cars, special meeting on cars. They're the ones who showed us, hey, guess what? Younger patients do better. You know, younger patients do worse because that's more likely to have ALL than adults. And waiting on your CRS, you often have a higher grade. And the target antigen CD19 at the time, BCMA, was not, that was very small numbers at the time, but it was still CD19 was more likely. And again, this is another, odds ratio saying what predicts for severe CRS. Again, it's how high your temperature is. Do you have ALL? Did you get a CD28 product? And also, did you get late intervention? So that's a little bit of CRS. I'll skip this one. And so how do we treat it? What is it? So again, this is the grading system. I showed you the ASTCT grading system. Well, we actually developed our own strategy, or we've now endorsed. This is the strategy of how we treat. For grade 1, we watch. And we typically don't use tocilizumab until we have fevers. If it's just fevers and they're not like 39.5, we'll wait 24 hours. But at 24 hours, we will, if there's still febrile, we'll use tocilizumab. We use acetaminophen first and also rule out infection. If we're using oxycabtagene, there is some data to say if you decide to use toci only and no dex, that it may be better to do a single dose of dex 10 milligrams, because sometimes the toci will mask your onset of ICANS, and then your ICANS is more severe. For grade 2, we're going to actually immediately use toci. We will repeat it every 8 hours up until we say 3 doses in 24 hours, and then we will allow 1/4 dose. After 4 doses, we're done. We're not going to use, we're saying that person's toci resistant, and we'll look for other therapies. And you'll see steroid use. We could sometimes use it if they don't, in that after 24 hours for grade 2 of 3 doses of toci, we'll start steroids. For grade 3, cytokine release syndrome, some of them will consider they need an intensive care unit because they may need a vasopressor or they may need, high flow oxygen. We're still following the tocilizumab rules, but we're often now going to dexamethasone 10 milligrams every 6 hours or a milligram per kilogram of methylprednisolone twice daily. We also use a lot of anakinra now, and I'll talk about that a little later, but we don't use the 100 milligrams sub-Q or 100 milligrams IV once a day. We go 200 milligrams 3 times a day for 7 days, and then 200 milligrams for 5 more days. So covering 12 days if we really think someone's got very advanced CRS. It's grade 4. Now we're into trouble. It's life-threatening. Those patients are in the ICU. We use, instead now of a milligram per kilogram, we're using 1 gram of Ciamedrol daily for 3 days, and then we taper over 3 more days down to 1 milligram per kilogram. And again, we're often using anakinra with it. Anti-IL, so tocilizumab is an antibody targeting IL-6. Anakinra will block IL-1. And this gives some other things that if you start to have someone with persistent and prolonged cytokine release syndrome, well, we're going to look for other salvage therapies. So macrophage activation syndrome has to be thought about. Remember I said there's other immune populations. Hemophagocytic lymphohistiocytosis also needs to be considered. You know, because we'll see ferritins go from 2,000, 4,000, 5,000, 20,000, 50,000. And sometimes we do follow ferritins every day, but sometimes you don't want to miss looking at that because that's the clue that you're getting into a bigger problem. If you see MAS or HLH, you really need anakinra. And then other second line strategies that you can be used once you decide that toci's not doing the job. We can use ruxolitinib as a JAK inhibitor because that'll block all inflammation. We use dasatinib. You know, we know dasatinib is a second generation TKI to treat CML, but it works by blocking LC. It also has other tyrosine kinases that it blocks, including the intracellular lymphocyte kinase LCK. When you activate the T cell receptor, it actually triggers downstream events to activate IL-2 production through LCK. Dasatinib can we can actually help and block that. Siltuximab is another anti-IL-6. We tend not to use a lot of that, but if it doesn't respond to Rux or dasatinib, you could think about cyclophosphamide. Now we get into ICANS, the neurotoxicity. Very similar. The definition of ICANS, that's immune cell associated neurotoxicity syndrome. It's any pathologic process involving the central nervous system following immune therapy that causes activation or engagement of T cells. And you could be slowly progressive or it could be rapidly progressive, but it can be aphasia, altered level of consciousness. You could have coma. You could have difficulty thinking, motor weakness, seizures, cerebral edema. And a lot of people have adopted what they call the ICE score. And you can make up your own, but you have this, basically you're testing multiple aspects of cortical function. Orientation, the ability to point and name a object, the ability to remember something, ability to follow command. Writing. We tell every patient to make a sentence. And what they do is we ask them every 8 hours when we test for this, we ask them to write the sentence. And it's amazing how the sentence, the writing could be absolutely identical. And then all of a sudden you see micrographia, you see like stuttered words, and all of a sudden, because the dysfunction, the dysmetria becomes very prevalent. So again, there's a toxicity grading guidance system. The grade 1 is usually we just observe. Sometimes it's a little sleepiness. Sometimes it's just a little word finding. It gets deeper and somnolence, or, we're aware and we are going to intervene at grade 2, as I'll show you. At grade 3, it can be severe disorientation. Patients won't even know their name. but they'll still be able to do some activities. But by grade 4, they're obtunded, and they often need mechanical ventilation. And so how do we treat it? Grade 1, if we see it, we'll consider giving someone anti-seizure meds. We want to make sure they stay safe. We do follow them. Our usual CRS guidance was we check maybe Q8 hours, but we're going to now look every 4 hours for vital signs, and we're going to look at ICE scores, the neurotoxicity cognitive scores every 8 hours. Once we start to see grade 2, we immediately start activity. If we haven't already done it, you're definitely going to get anti-seizure meds. We will start treating steroids. If there's concurrent CRS, we use tocilizumab. And then there's procedures we say at the discretion of the team. Now, a lot of people have published you should do these things. What we do is we say, should we do these things? Do we do a swallow assessment to make sure that they're protecting their airway? Do we think it's seizures? Do we check a bedside EEG? A lot of patients, they say, oh, an MRI is the best test to get. Well, when people start to get tremulous or they're, combative, they're not going to be able to sit for an MRI or stay for an MRI without me sedating them. I don't want to necessarily sedate somebody aggressively for an MRI. So I'll use just a head CT. If that looks good, we can do a lumbar puncture, consider. And we actually do follow occasionally, if we're going to do the lumbar puncture, to check pressure, to check opening pressures and check to see if the cells are in there. Because you can actually see CAR-Ts in the CSF. We often will do what was developed at Medical College of Wisconsin, where they do a triple therapy intrathecal at the time of the lumbar puncture. We try to have an evaluation of papilledema by our ophthalmologist. A lot of our patients are just too combative to let that happen. And so you still have to make it safe. So we preferentially will use haloperidol in addition, frequent through the daytime. Overnight, we use olanzapine or quetiapine, and sometimes we still use lorazepam, but usually not for grade 2. For grade 3, now we're worried about aspiration. Everyone has their head of the bed elevated. We have them on telemetry. We have dose, dexamethasone not to exceed 10 milligrams every 6 hours. Now we are going to do anakinra. Typically, what we do is we watch someone with neurotox. If they do not, if they don't improve by a grade or worsen, we start anakinra for ICANS. And then we always, at that point, will get neurology involved. Not that we usually are teaching the neurologists, but we want them there because of these patients, they go to the neurosurgical ICU, not to the medical ICU. And finally, for grade 4, again, very similar, but if we see cerebral edema, now we're going to think about mannitol or hypertonic saline to shrink the brain. And we're going to be working very closely to keep that patient and keep them alive. We have had patients with status epilepticus that have broken through Keppra. We have the second agent, lacosamide, to control seizures. This is again from the FDA's database analysis. Older patients are more like, Axicel at the time with its CD28 more likely to be linked. Older patients more likely to get this. Same thing, I'll just skip this. And they do point out, though, this was also from the IBMTR from a couple of years ago. They may have updated it. They have updated this. And these data will be updated at the coming up ASH meeting. But if they looked at the first, I want to say almost 1,800 patients treated with CAR-T, that's what this slide's from. 35% of patients had independent CRS only. Only 7% had ICANS without CRS. 64% of patients, if you have ICANS, you have coincident expression of CRS. And so this points out that this is these numbers from the IBMTR. Tisacel, high rates of CRS. ICANS was only 25%. Axicell, much higher ICANS. Again, Axicell also higher ICANS. Brexocell, these are all CD28. These are the C41BBs. ICANS are higher. Same as the CRS tends to be higher. So, okay, I'll finish up in 5 minutes. I know this may seem boring, but this is the basis of how you run a program. And so these are management guidelines. And I figured, this was on our list of topics. How do we run a program? So that's what I'm trying to give you. So the next piece that I think is really important is we have 5 main docs. There's really three of us who mainly see most of the CAR T patients. There's 2 pediatricians on the adult side. There's 2 pediatricians, Dr. Nemechek, Dr. Chang, who sees on the adults on the pediatric side. So that's 5 main docs. But we have other physicians who are following and involved somewhat in the CAR T, our ALL docs, our myeloma docs. And so what we do is we have a weekly meeting where we review every single patient, and we say, are they eligible or not? And what we've came up with from the literature, criteria that we say will make them eligible. Now, these are a little more liberal than the original clinical trials. The original clinical trials said ECOG less than or equal to 1. We'll say we'll accept a less than or equal to. Real world data says that's acceptable. Real world data said cardiac function over 35% is enough. So these were the major criteria that would make someone eligible. And then we looked at some minor criteria. If someone meets all major criteria minor, they're automatically eligible. If they meet all major criteria, but they only meet 2 of the 4, they have to be discussed. And we basically say, at that weekly meeting, we have to have unanimous support of going forth. If one of our docs say, I'm not so sure, I think we're going to, it's going to hurt the patient. It's going to, we're not going to benefit them. We've agreed that consensus is the most important, and we will defer to the person who says we're not going to do it. Most of the time we've met consensus. We have had those young patients where the individual person, doctor taking care, says, I really want to do everything I can for them. But you sit back and say, you know what? You're not going to make them better. They're going to die. We know they're going to die. All we're doing is not dealing with reality. And so this turned out to be a really important step for our program to put these management guidelines in place. We think infection prophylaxis is important. So at the time of screening, we screen for HIV-1. Well, we screen for all of these infectious disease. We want to know if they've had it. Some of the companies want to know if you have someone who's had prior HIV, you can make and treat them with CAR, but not if they have an active viral load. So we screen looking for the NAT is the nucleic acid testing. You're looking for active viral load. And then we also test for things we want to know, HSV, toxo, and EBV, because when someone's very, very immune suppressed, those may become a problem later. They're not really necessary according to the companies who manufacturing CAR T, but they're important for us for clinical guidance. And then we have prophylaxis strategies we use for based on the, what the white count is, what the neutrophil count is, and also what the CD4 count is for PJP. Pneumocystis is common. I just actually had a patient who developed pneumocystis who's a year out from CAR T therapy, in remission, doing well, and got very severe pneumocystis pneumonia that basically took about two or 3 months to clear because her CD4 count was still only about 100. We also think it's important to monitor immune recovery. So we have a series of simple assays. One is immune globulin IgG level. One is a CD4 count. There is a commercially available cytokine panel, 13 cytokines, and we actually measure that over the first month extensively because that gives clues about the height of CRS you can experience. So we do that. And we have a very detailed immune reconstitution panel, the one we use for allogeneic transplant. We use periodically in our CAR T patients, measuring immune recovery. And again, this applies to anyone who's received IEC therapy. Finally, this is the final important thing. You're going to do CAR on somebody. You have a patient. Well, they've been on treatment. When do you stop treatment? Before leukapheresis? When do you stop treatment before infusion? Well, what we've done is come up with a schedule. If you've had an allogeneic transplant and they've relapsed, we need at least 3 months before we consider CAR T. If they've gotten clofarabine or Campath, we want 2 months. And we could see a strategy that's come together. We built this a lot from the literature. I asterisked the monoclonal antibodies and the radiation therapy because since when we developed the management guidelines, some of the more recent data shows that you can be a little bit more liberal, and we're doing monoclonal antibodies now at maybe within 2 weeks before you collect someone for leukapheresis, and radiation therapy up to 1 week before. Radiation therapy can cause a systemic abscopal effect, and you radiate locally, but you can actually cause cytopenias. So we want to give some window, but that's what this was based on. Similarly, okay, you've got your cars, the company's manufacturing them. Well, I know I'm going to be treating that patient soon. When do I stop? And when, because I want to use bridging therapy. Well, you got bridging therapy, you have, antibodies, immune suppression. We have a guidelines for when do you stop your treatment prior to the cells go in, because we want lymphodepleting therapy to do its job, and we want the CAR T to do its job ultimately. So I'm going to stop there. I didn't know how fast or how long it was going to take me to talk. I always talk. But I also put some case histories, but I'll save that for a different time. So I know this, as I prepared this, I knew this was sort of boring, but I also know that this is nuts and bolts. And sometimes you spend a lot of time talking theory, to talk about, the biologic pathways, but nuts and bolts are also important. So I put this together for you. I hope this is useful.
So, Richard, thank you very much for your comprehensive review. This is very necessary for practical CAR T cell therapy. Very, very, very important. Thank you very much.
Yeah.
So I have questions for you, Richard. For allo CAR T cell, do we need to have at least HLA typing for the donor?
Well, it depends which allo you're using. So if you have a patient who had ALL and they transplant the patient, you got the CAR T. If you collect the T cells from the donor, like, okay, the recipient, I mean, those are all donor, but they may be tolerized. You're going to make CAR Ts out of them. But there have been cases, you're right, where someone who's had an allogeneic transplant and then they relapse, but your sibling donor is nearby. So you get the sibling donor, you make CARs from them. There's always the worry that you're going to adoptively transfer GVHD, but typically the generation of the CAR T has been so effective that you can actually give the CAR T. You could give the CAR T cells. It's the same HLA type as the recipient, so you don't need to do anything different. The big question: do you need immune suppression? I would say if I decide to add Tacro, I would add it after. I wouldn't do it for the first month, but I would do it afterward. Now, the off-the-shelf CAR T that's being generated, like Allogene has, we're collaborating with CRISPR Therapeutics. CRISPR Therapeutics has one. they've all done genetic engineering to knock out beta 2 microglobulin, because by doing that, it knocks out the HLA, which then protects it from destruction from the host immune system. The other thing then is it's sensitive to NK cells. Well, I was just at a meeting just with a company who's got a new CAR, and we were talking. They're actually, so they're knocking the CAR into the T cell receptor alpha locus, so you lose expression of endogenous T cell receptors, so you will not get adoptively transferred GDVH. They're knocking out beta 2, so you will not get immune rejection from the host when they start to recover. But they also are knocking in an HLA-E. An HLA-E will turn off endogenous NK cells. So that the world of there's no currently approved allogeneic CAR T product, but I do think there's a lot of benefit available to the world if that can be done successfully and safely.
How about haploidentical donor for CAR T cell?
I'm unaware of that being done currently.
Mm.
You know, honestly, it's almost all autologous. And if you're doing the only setting where someone is doing like autologous allo is when it's a transplant and it's been done. And you're right, theoretically, the haplo could be done there, because if it's a patient who's been transplanted with a haplo donor, they've now got haplo engraftment. So, and then if they recur, you could theoretically use the haplo for CAR T. I'm unaware if that's been done. I haven't seen any anecdotes or reports on that. It's a great question.
Good.
And you're right, it's very real right now, considering the growth of haploidentical transplant in the world.
Right. Mm.
I'm going in 2 weeks. There's going to be a United States with the NIH is sponsoring a relapse conference. It's just 2 days completely devoted to what we do after relapse after CAR T, what we do after relapse after transplant. If anyone's doing that study, I should hear it at that meeting.
The best way is to prevent relapse.
Well, preventing relapse is a whole other world, but this is about like what to do when you relapse.
Yeah. Thank you, Richard.
Well,
What
anything
else?
else from folks? If not, I would say, again, if you decide to come, Halloween is only 4 days away for all of you. Just come over. And if you go to Justin's house, he is going to be handing out those, almost 1 pound Hershey bars. So that alone is worth flying across the Pacific for.
Very good.
Thank you. Happy Halloween.
I got my Batman tie on special for you guys.
Right.
Thank you very much, Dr. Richard. Very,
Good job, Richard. Thank
very
you.
advanced knowledge. Learn as always.
Well, it was one of the ones we actually had it on the list, and it's so practical. Sometimes it's boring to do, but on the other hand, this is the foundation. You grow from here. Once you create this is our foundation, and we use this we constantly, as a group, I'd say every 3 months, we come back to this set of guidelines we've set up, and we just take one of those Monday meetings and say, do we still believe this is all appropriate, or do we need to modify? Because of all these standards, you set a standard, it just allows us to explore how to do it better.
Yeah. Yes. You have very good system, and I think this is very important. As I said before, I very much agree with you. Yeah.
Yeah. All right.
Um,
Well, yeah.
Anyone have one last question before we finish? We have 5 minutes. Anyone? nursing side คุณไก่ anything from you
โอ้ค่ะอาจารย์ Thanks
สมิติเวชคะ any basis you like to ask confirm your doubt or anything
I think lecture of Professor Lishas is quite a lot of detail. I think I'm okay.
okay thank you very much everyone and see you in November once again in video conference
Okay. All right, well, we'll reconvene. We'll look forward to it.
Okay, Richard, thank you very much again, as usual, and have a nice weekend.
You too.
thank you
Bye-bye,
Bye.
everybody.
Sure, next time.
Bye bye. See you.
Bye.
อาจารย์วรรณภาว่าไง
หนูต้องเข้าประชุมกับอาจารย์เสิร์ช8 โมงหนูเลยเข้า CI BMTR meeting ไม่ได้นะคะหนูเลยขออนุญาตลา
เมื่อไหร่อ่ะ CIBPR เมื่อไหร่ไม่มี
วันนี้ค่ะ
ตอนไหน
เขา BHRC เขาส่งเชิญหลังจากไอ้ BMT ทุกเดือนที่เขาบอกว่าเขาเริ่มหลังจากconsulting visit ก็คือวันนี้ค่ะอาจารย์ไม่ว่างใช่ไหม
แต่ไม่ใช่เราประชุมกันเองใช่ไหม
ใช่
เฮ้ยผมไม่ว่างวันนี้ผมไม่ว่าง
อาจารย์ไม่ว่างเหรอ
ใช่
เดี๋ยวถ้าอาจารย์ไม่ว่างสงสัย
ผมไม่รู้เลยนะเนี่ย
BHRC เขาส่งอาจารย์ได้ไหมถ้าไม่ได้หนูจะได้ไปฟีดแบ็กเขาว่าอาจารย์
ผมอาจจะได้นะแต่ว่าผมไม่ได้ดู
ไม่เป็นไรคืองี้ที่ตกลงกันไว้ก็คือว่าจะจัด1 ชั่วโมงหลังจากมันลี่ไอ้เนี่ยวิดีโอคอนเฟอเรนซ์กับ OHSU เนี่ยค่ะ
เฮ้ยมัน
เข้าสัก5 นาที 10 นาทีก่อนได้ไหมอย่างน้อยอินสตรัคชั่นเขาว่าให้ทำนู่นนี่นั่นอะไรแล้วค่อยสวัสดีจบกัน15 นาทีอะไรอย่างงี้ก็ยังดีอาจารย์
งั้นต้องอีกสักพักหนึ่งขอเลื่อนไปสัก7:30ได้ไหม
ก็ไอ้ของเรามันไอ้นี่ไงอาจารย์มัน7 ถึง 8ไง
ขอเลื่อนเป็น8:30ได้ไหม
เดี๋ยวหนู
หรือ8:15แล้วกันเดี๋ยวก่อน
เดี๋ยวหนูจะโทรบอกทาง BHRC นะคะว่าให้รีอินวิเทชันเป็น8:15
โอเคได้ครับ
สวัสดีครับ
ค่ะอาจารย์ขอบคุณค่ะเจอกันค่ะ